So welcome everybody to our webinar this evening on neuroendocrine tumours, and we've got Associate Professor Michael, who's very kindly offered to come and join us and share his experience and expertise in this area. So we're so grateful to Michael. And so I'll just let you know who I am in case you're not familiar with me. My name's Kate Wakelin and I work with the Unicorn Foundation. I'm the NET Patient Support Nurse. So if you ring the NET Nurse line, you'll speak to me. Or if you email the NET Nurse email address, you'll speak to me by email. So more from me later, but I'm very keen to introduce Dr. Michael, Associate Professor Michael. Michael's from Peter MacCallum Cancer Centre in Melbourne and is a medical oncologist. And I've just said to Michael, you tell us about yourself and what you're passionate about, and I'm really looking forward to hearing what he's got to share with us tonight. So thanks everyone for joining us, and Michael, over to you.
Thanks everyone for joining us, and thanks Kate for inviting me. I'm a medical oncologist and I've been in practice for the last, must be about 23 years now, mainly in the area of gastrointestinal cancers. And over the last 10 years, a very heavy interest in neuroendocrine tumours. And really in support with our nuclear medicine team led by Rod Hicks. And we now have a neuroendocrine tumour clinic at Peter MacCallum with a specialist nurse as well. And we have a very strong multidisciplinary group looking after neuroendocrine tumour patients. So what I'm going to do today is just talk to you about the background of neuroendocrine tumours and what are they, how do they present, and how do we individualise the treatment of this rare but what we see is very common disease at Peter MacCallum. So I'll start the talk now. So neuroendocrine tumours arise from any site of the body, but in particular arise from any part of the gut and the embryonic gut, including from up in the chest, the thymus, the lung, the esophagus, liver, stomach, bowel, including small bowel, large bowel, and the rectum. And sorry, just getting this computer. And they're actually not as rare as people think. If we look at all neuroendocrine tumours in this graph of prevalence versus the types of malignancies, neuroendocrine tumours are actually more common than gastric cancers or pancreatic cancers for that matter. And that's because they often do present as small little polyps which are removed at the time of colonoscopy or gastroscopy, and also we're seeing more and more patients with them. And this is a graph of looking at the incidence of tumours versus time from the 1970s to the 2000s. This is data from the US, showing it with time, the incidence has increased for all neuroendocrine tumours by about 6-fold, from about 0.2 up to about 1.2 per 100,000 population. So we're seeing more and more patients. And I think part of that is greater awareness by clinicians looking after these patients. We're also investigating our patients more with endoscopies, gastroscopies, colonoscopies, and X-rays and CT scans. One of the other factors maybe perhaps there is environmental carcinogen exposure. We're unsure about that. We are seeing more and more. And really for family doctors and clinicians, we need to have a very high index of suspicion of neuroendocrine tumours. Generally, they do occur alone in terms of isolated lesions, but they can be multiple, popping up in multiple different organs, and they can be part of familial syndromes, such as MEN, for example. And if we look at how they present, so half of them present with localized disease in terms of the local primary and just the primary alone. And then the other half present either with lymph nodes or with distant metastases. So they're spread to distant organs away from the primary. And one of the interesting things we see about our patients presenting with neuroendocrine tumours is that some patients have very long histories of symptoms before they're actually diagnosed. And some patients can have vague abdominal symptoms, abdominal pain or intermittent diarrhea or intermittent flushing, they can go up to 5 to 7 years before they're actually diagnosed by doctors. And we often do see this in the clinic where patients are often diagnosed with irritable bowel syndrome for many, many years before someone clicks about diagnosis of neuroendocrine tumours. It's not an uncommon scenario. And if we just look at how they present, it really depends upon where they are, causing local symptoms. For example, if they're in the gut, they can cause bleeding or bowel obstruction or pain. Or if they go to other organs such as the liver or bone, they can cause local symptoms there. And sometimes these tumours do secrete hormones, causing hormonal syndromes. And they can actually secrete a whole variety of different hormones. The carcinoids often secrete serotonin. Sometimes the pancreatic tumours secrete glucagon, insulin, gastrin, for example. So a whole variety of different hormones they can secrete and therefore cause particular syndromes as well. If we just look at the carcinoid syndrome, which is probably one of the commonest syndromes, if we look at what it does to skin, because of the serotonin production, it causes flushing, it can cause cough and wheeze and shortness of breath, it causes diarrhea and cramps and nausea, it can cause scarring in the abdomen, and it can also cause scarring of the heart valves. And we do have some of our patients actually needing heart valve replacement. One of the commonest sites is in the small bowel, and often we do find that patients do present incidentally, so we just find a lump in the small bowel just because we've x-rayed this area, not because the patients have symptoms. Or sometimes patients may have non-specific abdominal pain. They often may have diarrhea because of hormone production. If it's a localized mass, it can cause a bowel obstruction or bleeding. Or sometimes they can cause scarring around the bowel, which causes the small bowel to become gangrenous, or causes what's called mesenteric angina, patients getting pain in the abdomen on eating because they can't get enough blood supply to their bowel because of the scarring. And the carcinoid syndrome occurs in about 20% of patients with small bowel carcinoid tumours. And usually, almost all patients have liver metastases to have carcinoid syndrome. And as I said, some patients have carcinoid heart disease, in about 10% of patients with carcinoid syndrome, where they have scarring of the heart valves, especially on the right side of the heart. And some patients with very severe carcinoid syndrome can have pellagra, which is niacin deficiency, because of the excessive requirements for niacin for hormone production, causing diarrhea and rashes as well. This is just a CT scan that I'm showing here of the abdomen. This is the front, the back, the right, the left, and you can see this soft tissue mass here from a small bowel carcinoid. This is just a frontal view where the chest is up here, the pelvis is down here, and here's the liver, and here again we have this mass of node and the small bowel primary there. So how do we confirm the diagnosis? One is we generally do blood tests looking at tumour markers, and a common one we use is chromogranin A. If the patients have carcinoid syndrome, such as flushing and diarrhea, we'll measure the urinary 5-HIAA. We often do blood hormones, especially for pancreatic neuroendocrine tumours, such as gastrin and insulin. If we want to assess heart function, we send off a blood test called BMP. And if they have carcinoid syndrome, we'll do an echocardiogram and an ultrasound of the heart. And then we look at how far the disease has spread, and we'll often do a CT scan, an MRI of the liver. We'll do special scans called somatostatin receptor scans, phytonoctreotide scan, or GAT8 PET scan. And if we think patients have more aggressive disease, we'll do a sugar PET scan or an FDG PET scan, which I'll talk about later. One of the interesting things about these neuroendocrine tumours is they have hormone receptors or somatostatin receptors on their surface. And up to about 80 to 90% of these patients have these receptors on their surface, and there's 5 different types. We can actually use that to our advantage because we can actually use that to find these tumours. This is an example of a GAT8 PET scan, a frontal view of a patient who we give GAT8, which is has a hormone plus a radioactive atom, and we put it in the PET scanner, and we can see that the patient has disease spots in the lymph nodes and the bones and lymph nodes within the abdomen as well. This is just a cross-sectional view showing multiple liver lesions from the neuroendocrine tumour showing up on the PET scan and also in the pancreas. And this is a CT scan. You can just barely see the lesions on the CT scan. And so often we find that the GAT8 scan will pick up at least 30 to 40% more lesions than a CT scan will pick up. So it's a very sensitive tool. This is another example of one of our patients with a pancreatic neuroendocrine tumour. This is a frontal view showing a nodal mass on CT scan, and it lights up quite nicely with the PET scan as well. And we often see that patients that have very slow growing tumours, the disease shows up very well with the GAT8 scan. And as the disease becomes more aggressive, they have a higher proliferation rate. We find that the tumour becomes less GAT8 avid and takes up more radioactive sugar PET scan. These cells are dividing more quickly. And this is a slow-growing neuroendocrine tumour of the small bowel. This is the GAT8 scan showing multiple liver lesions and the small bowel primary. And as we'd expect, if we do a sugar PET scan, the sugar PET scan, apart from showing the excretion of the radioactive sugar in the kidneys and the bladder, doesn't show any disease at all, telling us that this disease is very slow-growing. But then again, we have this patient here who has a GAT8 PET scan on this side, showing a few lesions within the liver only, but most of the disease lights up on the sugar PET scan, showing that within her own tumour, there's different lesions which light up with the GAT8 scan, others with the sugar PET scan, showing that she has a whole variety of growth patterns within the tumour in different lesions. So the way we manage our patients is that we individualise treatment based upon how quickly the tumour is growing in terms of tumour grade, where the disease is, based upon CT scans and MRIs, and based upon PET scans as well. Interestingly, some patients have very unusual growth rates. If we look at time at the beginning when they're first diagnosed, and this is years on the bottom here, we can see that some patients' disease grows very quickly, others grow at a very slow rate and then suddenly may become very quick growing. And we have other patients that grow very, very slowly. And it might be over decades that we watch these patients and the disease grows very, very slowly. So we individualise treatment based upon that growth rate. And there certainly are some patients where we just wait and watch. And over several years, their disease does nothing and just remains relatively static and asymptomatic. So there's various treatment approaches, and you really need a team of specialist surgeons, nuclear medicine doctors, hormone specialists, heart surgeons, and radiologists to try and manage patients with this disease. And treatment includes surgery, hormonal therapy, treatment directed at liver lesions, radioactive octreotide or PRRT, chemotherapy, and the biological agents. And I'll talk about each of these different aspects. Surgery. If we can remove the tumours, we remove them by surgery, especially if it's localised or if they've got very limited disease, for example, in the liver, we try and resect if we can. And we generally hopefully get a 100% 10-year survival rate. There are some patients where we cannot remove all their disease, but they may have severe symptoms because of liver disease, for example, or because of hormonal production. They're not responding to anything else. In those patients, we may actually debulk their disease, take as much disease as we can, realising it's not a curative approach, but it does relieve symptoms. This is a GAT8 scan of a patient. This is a cross-section of a patient's pelvis, front, back, right, left. Here's a small bowel mass within the pelvis, and that can cause trouble because of scarring and bowel obstruction and diarrhea and pain. So patients often with small bowel carcinoid tumours we often do remove them by surgery, especially if they're symptomatic. If they've got liver lesions, we try and destroy the liver lesions with radiofrequency ablation. And there has been some patients who have undergone liver transplantation, not in Australia, with a 2-year survival rate of about 60%. But now with modern therapy, I think we'll find that most patients will shift away from that. Let's just talk about the medical management of these tumours. Really based upon, as I said, the growth rate or the grade of tumour. And we use what's called a grading classification, grade 1 to grade 3, based upon how quickly the cells are growing. And grade 1 is less than 2% proliferation, grade 3 is greater than 20%. And we use special stains, and our pathologists look at how the cells are dividing in the specimen to determine whether they're grade 1, 2, or 3. And if we look at survival rates for all patients for all stages, this is survival from 0, this is 100% versus time from 0 to 10 years, you can see that patients with slow-growing tumours survive much, much longer than those patients with very rapidly poorly differentiated tumours or high-grade tumours. So really the growth rate is really quite an important determinant of survival. In terms of hormonal therapy, we know, as I said, that these neuroendocrine tumours have hormone receptors on their surface. And when they're stimulated, it causes the tumour to grow, secrete hormones, divide and spread. We now have agents called somatostatin analogues, or SSAs, which can block those receptors and stop the growth of these tumours and control hormone production. These are the somatostatin analogues, and most of you will be familiar with this, and these include octreotide LAR or sandostatin LAR or lanreotide, and they decrease hormone production in about 80 to 90% of patients in terms of diarrhea and flushing. They decrease urinary 5-HIA in over 50% of patients, but they also have what's called an anti-proliferative effect. They do slow tumour growth down, and that's been proven by recent trials. One of the most recent and largest trials is the Clarinet trial, which looked at patients with neuroendocrine tumours, and patients were either treated with lanreotide versus placebo. And most of these patients had pancreatic neuroendocrine tumours, also others had midgut, small bowel tumours. And compared to placebo, the lanreotide controlled the tumour in about half the patients for at least 30 months compared to about 18 months for the placebo. That's telling us that the hormone injections slow tumour growth down. Because these tumours have hormone receptors on their surface, and we can use that to use the GAT8 PET scans to look at the tumour distribution, we can also treat the tumours with hormone receptors on their surface with radioactive atoms. And we have a whole variety of different radioactives that we can use, and we attach the radioactive atoms with the hormones, such as octreotide, which binds to the surface receptors, the somatostatin receptors. And the tumour cell then takes up the hormone with the radioactive atom then goes into the tumour cell and burns the tumour cell from within inside. And we use PRRT or radioactive octreotide therapy in those patients whose symptoms can't be controlled with standard medical therapy or whose disease is progressing. And importantly, all types of disease must have very high levels of hormone receptors, as we judge by the GAT8 scan. You have to express the target so it can target it properly with the radioactive atoms. And the initial studies were performed in the Netherlands, reported about 10 years ago now, showing patients, over 80% of patients having either stabilisation of the disease or decrease in their size of the disease. And it also shows this survival curve of number of patients versus time, showing you that those patients that had a response to the radioactive treatment had a much longer survival compared to those patients whose disease progressed despite the radioactive treatment, with overall survivals at least up to 40 months in over half the patients. And it's very similar to what we have in our own practice as well, but we're much more selective. This is just an example of one of my patients who had a pancreatic neuroendocrine tumour whose disease was fairly extensive in her bones and liver and lymph nodes. And this is the GAT scan at baseline. And this is 3 months after she finished PRT, and it shows that most of the disease is almost completely resolved. And this is now 10 years ago, and she's still well and asymptomatic at present. This is another example of one of our other patients who also had a baseline GAT scan with multiple liver lesions. And then with treatment with PRT, the liver lesions are slowly decreasing with time. And we've seen some patients that have had very, very prolonged responses over several years with PRT. We now have what's called a randomized study now reported last year, where patients who are treated with sandostatin LAR 30 milligrams are either treated with PRT versus higher dose of octreotide LAR. And if we look at their disease control over time, those patients that had PRT had a much longer disease control compared to the higher dose of LAR. And the disease control was over about 80%, much higher than those patients that had the higher dose of sandostatin LAR. And it looks like that patients receiving the radioactive octreotide may have better overall survival, but still very early days yet. We need longer follow-up. Well, let's talk about the biological agents which have now been available in Australia for the last 12 months or so. And the first one is called everolimus, which is an mTOR inhibitor. And then everolimus has been approved in Australia for pancreatic neuroendocrine tumours. There is not approval for any other indications, but there are compassionate access schemes through Novartis, which we've used for some of our patients. mTOR is an enzyme in the neuroendocrine tumour cell, and it's a driver. It's like the central powerhouse of the cell. It makes the cell's energy. It drives the cell to proliferate and divide and spread. And everolimus inhibits that enzyme to stop the cell activity. And there's been a couple of what again is randomized trials. The patients were randomized to everolimus versus placebo. And the first one was for pancreatic neuroendocrine tumours, again showing a survival advantage in terms of disease control rate relative to the placebo. And there's been another trial published last year called the RADIANT-4 trial, which looked at non-functional neuroendocrine tumours from the bowel or from the lung. And it again also showed disease control relative to placebo, very similar to the first trial. And we now have sunitinib, which is a drug which stops the blood vessel supply to the tumours. And sunitinib is used in kidney cancer and gastrointestinal stromal tumours, but it's now being approved for use in pancreatic neuroendocrine tumours. And in this trial, they randomized patients to sunitinib versus placebo and found again that there was a better disease control and progression-free survival compared to the placebo. A very similar advantage compared to everolimus. And it's also been approved in Australia for pancreatic neuroendocrine tumours. In those patients that have a lot of liver disease and a lot of symptoms from their liver disease, or who have disease which is very aggressive within the liver, whilst the rest of the disease in the liver is very slow growing, we can use liver-directed therapies. We can either use what's called hepatic arterioembolization, or TACE, or radioactive thirst spheres. And there's a very good body evidence of using thirst spheres in neuroendocrine tumours, with control rates ranging from about 12 to 20 to 60%, depending upon the publication. Now let's talk about chemotherapy for neuroendocrine tumours. We generally use that for patients who are symptomatic from their disease or hasn't been controlled with somatostatin analogues or PRT or drugs like everolimus. But in patients with very aggressive grade 3 disease, we often use chemotherapy up front. And there's a lot of publications with chemotherapy using the older regimens with streptozotocin and 5-FU, and more recently we've been using capecitabine temozolomide, which is also showing very good activity as well. And in the higher grade tumours, the grade 3 tumours, we've been using cisplatin etoposide for a very long period of time. So if we look at the 4 principles of treatment of NETs, either surgery for trying to obtain disease control or resection of all the disease and prevent symptoms and complications, symptomatic treatments of somatostatin analogues, the biological agents such as sunitinib and everolimus, PRT, or liver-directed treatment. If we want to try and slow the tumour growth rate down, we can use somatostatin analogues, the biological agents, PRT or chemo. But we also have a group of patients where you just have watchful waiting, where those patients whose disease is not growing or very, very slow growing, not causing them any symptoms, where watchful waiting is quite appropriate. In other words, trying to do no harm. And the management of neuroendocrine tumours is multidisciplinary and involves medical oncologists, pathologists, liver surgeons and upper GI surgeons, nuclear medicine physicians, specialist radiologists, hormone specialists, and heart specialists and heart surgeons as well. Thank you. Any questions? So, Kate, do you want me to go through the questions that have been typed here?
Yeah, look, thanks, Michael. It's been fascinating listening to you talk, and because just thank you so much. You've covered so much information and really clearly in such a short period of time. There was a couple of questions here, so we'll address those, and we also had one or two that were emailed to me beforehand, which we can also address, and I write a few things down as well. So I think, we'll start with what was typed in the box here and what was, actually we might start with one that was emailed in while people write a few things. I can see a couple of people are writing some more questions in the question box. So, but a question that we had emailed in was someone who's actually been on sandostatin. So I'll read the question out because it's here on my screen. I've been on sandostatin for 2 years and have had extreme diarrhea and pain over this period. Since stopping the sandostatin 8 weeks ago, this has improved substantially. Do other patients have this experience with sandostatin, and if so, are there any alternative measures to slow tumour growth? So I wonder if you've got some thoughts about that, Michael.
That's a good question, Kate. There's about 10 to 15% of patients that have those sort of problems with the somatostatin analogues. It's mainly due to the fact that the injections cause the bowel not to absorb bile acids which are produced by the liver, which enter the bowel, causing the diarrhea. And some of the things that we use is you can use things like Questran. Questran it's a powder, comes in a sachet which you dissolve in water, and you can use that 2 or 3 times a day. It's used for lowering cholesterol, but also has the added benefit of binding bile acids and stop them causing diarrhea. So I've prescribed that to patients to trial that. Sometimes the somatostatin analogues may cause malabsorption and not allowing your food to be absorbed properly by the bowel. That may respond to Creon tablets, which are pancreatic enzymes which come in capsules, which you take just before snacks and just before meals. And if it really becomes bothersome, you can either try and reduce the dose of the sandostatin, or sometimes even change patients from sandostatin to lanreotide, and some patients may tolerate that better, or vice versa. And if it really becomes difficult to control, then you might have to look at other ways of controlling the tumour, such as PRRT, if the disease is suitable for that, or everolimus or drugs like that, for example.
Thank you, Michael. Is there, I know a lot of people talk about, side effects on, if they're on sandostatin, or on lanreotide. Can they swap? What would be the... It's
worthwhile trying to swap. I think it's worthwhile trying. Not everyone gets away with that, unfortunately, but it is worthwhile trying that. And we see patients that have side effects with lanreotide, and we swap them over to octreotide, and vice versa. It's worthwhile trialing.
And Michael, I heard there's been a couple of things online about a new somatostatin analogue, and I'm just trying to remember the name, Telirostat, I think.
Yeah, Telirostat is not a somatostatin analogue. What it does, it actually blocks the serotonin production by the neuroendocrine tumours. So those patients that have carcinoid syndrome, which is very difficult to control with the octreotide or lanreotide, Telirostat actually stops the production of serotonin, and therefore it's been shown to reduce flushing and diarrhea in these really difficult to treat cases. And so they've done major trials in Europe and US, and we've also been involved in the trials with Telirostat as well. And it looks like now the company that's making it is now trying to get PBS approval for it. And I hope it won't happen, unfortunately, for the next 2 years or so. But it is a very useful drug in that regard, especially in very difficult to control hormone problems from the serotonin production. But it doesn't actually control tumour growth. So it doesn't work like somatostatin analogues to slow tumour growth. But only what it does is reduce hormone production only.
So if someone was going to start that, Michael, and I know it's not available yet, would they stay on their somatostatin analogue and take that as well?
I think it would be worthwhile trialling that, to trial the anti-proliferative effects of the injections and plus reduce the hormone production as well. Yeah.
Well, thank you. That's really interesting. Thank you. I'm just noticing there's a couple of questions here. One from Helen. Why do some people have chemo plus lutein? And I guess we're in the middle of the control net study, which is testing exactly that. But I'd love to hear your thoughts.
I think there is. I mean, in most other gastrointestinal cancers, we often combine radiation therapy with chemotherapy, and we've also been doing that with our neuroendocrine tumours with PRRT for now over 10-15 years. Initially with 5-FU given by pump, and now with 5-FU tablets, and more recently with 5-FU tablets and temozolomide. So there is and there's also been a study from the Western Australians looking at case side of temozolomide with PRRT showing very good responses. So I think it's obviously not standard across all the other neuroendocrine tumour centres across the world, but in our local experience we're finding good results with the combination. So we do try and combine chemotherapy with PRRT. And the controlled NETS trial is answering the question definitively for proper controlled trial is it better, chemotherapy with PRRT better than PRRT alone?
Michael, can I ask an add-on question to that? A lot of people ask me about what's the impact on my bone marrow from having a combination of chemotherapy and the PRRT.
Yeah, that's a good question. I mean, we do see patients just with PRRT alone of having low blood counts, especially platelet counts, and especially those patients with very diffuse liver disease. And we think that part of that is probably just basically the platelets become trapped within the tumours or trapped within the spleen, which gets relatively high dose of PRRT. And that's even in patients that don't have any bone marrow involvement. So we are very careful in watching blood counts post-PRRT, and especially if we give chemotherapy with PRRT, we keep a very close eye on blood counts. And if it does become an issue, then we stop the chemotherapy, just continue with PRRT alone if we can. but it's a very important issue, definitely.
Oh, thank you. That's really helpful. I'm just looking through the questions. There's a question from Catherine about pheochromocytomas, and I'm interested to hear your thoughts, but I also wanted to say I know I'm looking through the list of people and knowing that there's a couple of people who will be interested particularly in pheochromocytomas and paragangliomas, and we will be doing a webinar series specifically looking at the issues with these particular types of tumours because they are a little different in their management, and certainly a learning need for me too. But Michael, have you got any comments that you could share with us briefly?
We do see a few pheochromocytomas coming across Peter MacCallum. Often they're referred to us for PRRT, using the same type of agents as we use in neuroendocrine tumours as well. And we have seen in some patients very good responses. The other part of it is controlling the tumour growth, but also often with some patients with pheochromocytomas have problems with high blood pressure. So it's a matter of also treating their blood pressure, making sure their blood pressure comes under very good control as well. So they are very different spectrums of diseases compared to the neuroendocrine tumours, but they do have some similarities in the way we treat them.
Well, thank you, and I will look forward. This is one of the things we've had on our list for some time, is knowing that we want to look specifically at these things next year. So, Catherine, I know that's a brief answer, but sit tight because we'll have more coming soon about that. And there's also a question from Lisa. So I'm going to read it out because I need to read it to process my thoughts. I've had Whipple, which is removal of the pancreas, but never had a sugar PET, urine test or heart echo. I now have liver growth, but there's been no mention of resection. I see my oncologist next week and have been told I will be starting on monthly sandostatin injection. Should I be asking about PRRT and the other tests I have not had?
That's a very good question. In terms of the sugar PET scan, we only use it in patients whose disease grows very quickly within 6 months, telling us that the disease is aggressive. Or if we see disease on the CT scan but doesn't show up on the GAT8 PET scan, then we'll do a sugar PET scan. So it's an important tool in that regard. It gives us an idea of disease behaviour. And in terms of when the disease comes back in the liver, can you operate again? It depends upon the distribution of the disease. If it's a few lesions in the liver on one side of the lesion compared to the other, then you may be able to operate. But if there's multiple lesions across the whole liver itself, it's very difficult then to operate for cure. So it really depends upon the distribution of the disease. The other question is about PRRT up front. We would generally use somatostatin analogues first, and then if patients' disease progress, then look at PRRT at that stage. And that would be the sort of routine for most centres around Australia. Because PRRT does have its own complications itself, and it also has about a 1 or 2% risk of leukemia as well. We certainly have had a few cases of that in Peter MacCallum. So it's not something we tend to do up front for most patients. But I think you need to have that sort of discussion with your oncologist and have the appropriate investigations. I think look at all options.
Michael, what about the echocardiogram for that person, for Lisa?
We do, for all our patients with the small bowel neuroendocrine tumours, especially with carcinoid syndrome, we do echocardiograms at baseline. And we've actually had some patients present with a long history of disease, and then finally been diagnosed with neuroendocrine tumour of the small bowel and carcinoid syndrome, and we've done echocardiograms at baseline, find they have very severe heart disease. So we do it on all our patients with these small bowel neuroendocrine tumours at baseline, and then we do it once every 12 months as a routine to keep an eye on the bowel to make sure they don't get involved from the scarring. For the pancreatic and neuroendocrine tumours, I don't think that's standard to do echocardiograms because they often don't have problems with serotonin or production of the carcinoid syndrome, which can cause the scarring. But some patients do have carcinoid syndrome even with pancreatic neuroendocrine tumours. So it's individualised in that situation.
So I guess the take-home answer is worth discussing with your oncologist?
Yes, that's right.
Yeah, thank you. Now, there are a couple of questions. I might go straight to Jackie, and I'm going to come back to Martin. Jackie's asked the effect on the heart from catecholamine secretion from PHOs and PAROs. And should these patients be closely monitored by a cardiologist? What kind of diagnostic tests should they be having?
Well, the major thing is that the phagochromocytomas cause severe high blood pressure, and it causes the heart muscles to work a lot harder than it should, so it causes thickening of the heart, and the heart becomes very, very rigid. So obviously they're often under the combined care of cardiologists, endocrinologists looking at their hormone levels, and medical oncologists as well. So there is a combined team approach looking after patients with phagochromocytomas. The aim is to control the tumour, control the blood pressure, and therefore decrease the complications of high blood pressure on the heart and the other organs of the body as well. So we keep a very close eye on heart function, mainly through echocardiograms, and ECGs is probably the most important thing.
So does that mean that the hormones don't have the same impact on the heart valve as
no, with the phagochromocytoma, they don't cause any. The hormones produced by the phagos don't cause any heart valve scarring. So it's very different to the serotonin effects from the carcinoid tumour. And what the hormones produced from the phagos is that they cause they cause the production of normal hormones within the body, which causes blood pressure to go up. So they don't cause the scarring, though, of the carcinoid tumours. So it's very different hormones are involved.
Okay. Well, thank you. That's great. I've just noticed Jackie said my audio is dropping out. Jackie, that was bad timing, wasn't it? But you can catch up on the video. So that's a nice thing that we'll actually have this up on YouTube, so that if anyone's missed any bits of this information that we've been presenting tonight, then you'll be able to catch up via our YouTube channel afterwards. So thank you. Now I'm just going to check with. There's actually been a lot of discussion on our Facebook page about our next question. And that is the question from Martin, and he's asking your view on the use of immunology treatments or immunotherapies, such as Keytruda, and particularly for grade 3 NETs. And I think it's been an interesting conversation for the higher grade NETs, because there's been clinical trials available for Keytruda for the lower grade neuroendocrine tumours, but we've had quite a few people with the higher grade tumours who are saying, what can we do here? Is it worth a try? Is it worth funding this ourselves?
Yeah. I mean, I think the parallel to high-grade neuroendocrine tumours are the small cell cancers of the lung. They behave very similarly. And the anecdotal report, the trial reports that we're getting showing that Keytruda and drugs like Keytruda do have activity in small cell lung cancer. We're also hearing anecdotal reports that drugs like Keytruda also have activity in the high-grade neuroendocrine tumours as well, but we don't have any good trial evidence as yet. So I think it's early days yet. The Keytruda doesn't work straight away. It takes several courses to have it to fully kick in to control the tumour. Patients would have to self-fund, and it's about $3,000. No, it's about $3,000 per. No, $6,000, sorry, per 3-week course, so it's not inexpensive as well. And there are also now several trials of drugs like Keytruda coming in for neuroendocrine tumors, as you said, but for low grade, not for high grade. So I think it's early days yet. I think it's a matter of saying to patients, there is some anecdotal reports, there is some activity. Whether it's going to be of use in your tumour, we just don't know as yet. We don't have really firm, good quality data as yet.
Do you know, Michael, if there's any trials in the pipeline? Have you got any inside information for us?
Not with the high grades as yet. We are getting offered trials for the low grade neuroendocrine tumours, but nothing for the high grades as yet. But I'm sure their time will come. Okay.
Well, we'll hope for some rapid progress on that, because I know a lot of patients are really hanging out for that.
So they are.
Yeah. So I'm just looking to see if there's any other questions. Now, while this is your last chance to write any questions in the text box, I think we've addressed all of them, but send me a quick message if you think I haven't read yours out. I did have a couple of questions that I just picked up on during your presentation, Michael. I'm wondering if you mind if I pick your brains on. We had a couple of webinars with our dietitian, Kaylee Schneid, earlier in the year, which was fascinating. And she also mentioned about vitamin B deficiency.
Yes.
Do you recommend that all of your patients have routine vitamin B supplementation?
I think it's probably more important for the patients with the carcinoid syndrome, where the vitamin B is being used up by the tumours to make serotonin, the hormone which causes carcinoid syndrome. I don't know if I can recommend it for the other neuroendocrine tumours, but definitely for the carcinoid. And we are now actually, we now have a dietitian with an interest in neuroendocrine tumours, that Peter Mac, will be studying this issue as well in our own population.
Thank you. That's really helpful. I had another question, which was about halfway through your slide. You were talking about I've got my radar for medical jargon, and I saw a couple of words up there that I wasn't sure if other people might recognise, because I was like, ooh, what does that mean? And it was mesenteric angina. Can you explain, please?
What happens is when you have small bowel neuroendocrine tumours, the serotonin they produce causes scarring of all the tissues around the tumour and around the blood vessels of the small bowel as well. And it causes the blood vessels to become very narrowed. So when you normally eat a meal, the body says, oh, I need to digest all this food, so it sends all the blood supply to the bowel and opens up the blood vessels of the bowel to absorb as much of those nutrients as possible. And what happens with the scarring, it causes the blood vessels to become very narrow. So it's sort of like narrowing of the blood vessels of the heart. And then when you eat, your gut saying, give me blood, let me absorb all this food, and the blood's not coming because the blood vessels are narrow, so you get pain for the small bowel being starved of blood. So you're getting angina or pain similar to angina of the heart because you're just not getting enough blood supply to the muscle. So we often do see patients that get a lot of severe abdominal pain, which we call mesenteric angina, because, especially with meals, because of the scarring that the blood vessels are undergoing from all that hormone production. Okay,
thank you. That's a really great explanation and helpful. So that's great. I just had one other question, and I know this might be a sticky one, so I'm hesitating about whether to put it in, but I'm going to give it to you. And it's a question that lots of people ask me when they call me. And, you know, I had a lady who rang me a couple of weeks ago and said, my doctor's told me I've got 5 years left. And I wonder about the issue of prognosis. And I know it's a tricky issue. And I know one of the things that I know is that with the treatments changing so rapidly, what we know now is different to what we knew 5 years ago. So the people who are doing okay now, 5 years later, you know, if we were treating them 5 years ago now, then we'd be doing different things. But I just wondered if you had some thoughts or comments for people when they're thinking about asking about prognosis and the issue of prognosis.
Yeah, it's a good question. It's a really important question, and that's really one of the things our patients always ask us. It's a very difficult question, and I think you can always, when I say to my patients, look, you know, I can quote statistics based upon your disease distribution, based upon the growth rate of your tumour, as you know, from the biopsy of the tumour or from your PET scans, etc. And I can quote numbers to you, but they're generally pretty meaningless because each person's tumour is different to the other person. Each person's tumours respond differently to the other person. And as you said, we have more and more treatments available to us. And we also do a lot of novel things which, you know, some countries don't do at all. So I think it's a matter of saying, these are the facts. If I always ask patients, do you want to know prognosis or not? And they may say yes, they may say no. If they say yes, then I'll say, well, these are the figures based upon statistics, but you're an individual, your tumour's individual. It's very hard to say where exactly you'll be on that curve for most patients. And I think we have to have very open mind. And I see a lot of my surgical colleagues saying, oh, you only have 1 year or 2 years, etc. And I think that's a very wrong thing to say to patients.
Thank you, Michael. Now we're just almost ready to finish up, but I've just noticed that Martin has written a comment here. I'm just going to take a moment to read that just and see if there's anything else that we want to say about that. So he said, it's just talking about Keytruda. Okay. Oh, and Martin's just told us that unfortunately his wife passed away, and I'm so sorry to hear that. Martin, that must have been so tough. Yeah. So look, I think we'll close it off there. But look, thank you so much, Michael, once again. I really do appreciate your time, and yeah, you've explained things so clearly. So you know, thank you so much once again for that. And thank you everybody for. Thanks everybody for your participation and your questions and your enthusiasm. It's been a great evening.